online anesthesia video of this week. You can also participate in this program if you are interested. Just record your video presentation on Zoom platform and send to us in onlineanesthesia@gmail.com. For further rules and regulations, please visit our FB page online anesthesia. Let us watch this week's video.
Hello everyone. Welcome to online anesthesia video program. I am Dr. Rajesh, Senior Consultant Anaesthesiologist, Meenatchi Mission Hospital, Madurai. And I am here today to deliver a talk on applications of ultrasound for central neuraxial blockade. Let me share my screen here. Okay, so today's talk is on the applications of central ultrasound for central neuraxial blockade. Now, if you look back in the history of central neuraxial blockade, Dr. James Leonard Corning, American neurologist, was the first one to place a needle in the lumbar region between the two spinous process, and he delivered a large amount of drug to produce anesthesia and analgesia of the lower limb. In his documentation, there is no records for efflux of CSF. So this is considered to be a first epidural anesthesia rather than the spinal anesthesia. Later on, Dr. August Baer repeated the same procedure. This time he had the efflux of CSF and he had delivered the drug intrathecally. So this is considered to be the first spinal anesthesia. So from that day onwards, the spinal anesthesia is being widely used in the field of anesthesiology. So central neuraxial blockades, which include spinal or epidural anesthesia, are frequently used for both anesthesia and analgesia purposes. Even in pain medicine, there are a lot of spine-oriented pain interventions which plays a major role. And central neuraxial blockades are gold standards of obstetric anesthesia. And the success of this technique depends upon one's ability to identify the anatomical landmarks for needle insertion and also the tactile sensation for either intrathecal or epidural space identification. Now, if you look at the success rate of this central neuraxial blockade, even in difficult scenarios like obstetric analgesia or anesthesia, it produces a high success rate with a very low failure rate and very minimal complications. And this audit, which involved the major complications of central neuraxial blockade, had come up with good results that the complications related to central neuraxial blockade are very, very minimal. And it's always a landmark guided procedure, and it's such a simple procedure that identification of it depends upon the identification of the two spinous process and the placement of the needle exactly in the mid space and midline between the two spinous process. And it's a very common procedure being done by the anesthesia residents, and the success rate of even the residents are so high. So such a simple procedure, why we need ultrasound for this? So that is the biggest question to be answered. This procedure still have a lot of challenges, like the anatomical landmark, which is the gold standard, may vary among individuals. There may be scenarios of difficult landmark identification, like in patients with obesity, pregnancy, and edema, and there may be inability to predict the difficulty in needle placement prior to skin puncture, but the trajectory of the skin, the needling, and there will be difficulty in accurate prediction of needle insertion depth, and difficulty may be there in accurate prediction of first pass success rate. Now, the current methods of identification of the epidural space or the intrathecal space depends upon tactile sensations and the loss of resistance techniques. Eliciting this loss of resistance is still a blind technique. The failure rate may vary from 5 to 7%, even though the complications are rare, but they do occur in the form of intradural dural puncture, postdural puncture headache, and injury to the conus medullaris. There may be asymptomatic variation where we expect the spinal cord to end at the level of L1 or L2. There may be low-lying spinal cord too. So how come we can overcome all these problems? So now when you look at the landmark identification, the first step of central neuraxial blockade, how accurate we are. So there are a lot of evidences which says that the precise lumbar interspine identification by palpation is very prone to error. And the interspace can be identified only in 30% of patients correctly. And there is a tendency to identify a space higher than the intended. Now, the intercrystal line, the line connecting the highest point to iliac crest, uh, is supposed to cross at the level of L4, L5 space or L4 vertebra, but that will not obey the rule always. And it is not a reliable anatomical landmark for neuraxial anesthesia. And when Dr. Broadbent and his colleagues were studying about the ability of the anesthetist to identify a marked lumbar interspace, what they have identified is there are 51% of in 51% of cases, the level of identification was assumed to be higher, and also they were able to correctly identify only in 29% of the patients. It doesn't matter whether it is sitting or lateral position, but the mark identification is in bigger wrong in a bigger way. And when image guidance in the form of ultrasound was used by Dr. Watson and his groups, they were able to suggest that the ultrasonography may be a useful adjunct to safe subarachnoid anesthesia. But their study was involving a small group of 17 patients. When the same study was done by Furness et al., an evaluation of ultrasound imaging for identification of the lumbar intervertebral level in a large scale, what they have predicted is ultrasound imaging can identify the correct level in up to 71% of patients, while palpation can identify only in 30% of patients. So this results wants each and every anesthesiologist to get well versed with ultrasound guided or ultrasound in spine imaging. So this opens up the topic of neuraxial ultrasound. So if you look back the neuraxial history of neuraxial ultrasound, it's not a new procedure. In 1971, Bogin and Stulin were probably the first to report the use of ultrasound for lumbar puncture. This happened in the Russian literature. Later on, Porter and his colleagues in 1978 used this ultrasound technology in pediatric spinal canal in diagnostic radiology to measure the diameter of the spinal canal. The first group of anesthesiologists to use ultrasound was Koch and colleagues, and they used it to locate the landmarks relevant for the epidural anesthesia. This gentleman, Dr. Thomas Grew, did a lot of studies and researches related to central neuraxial blockade, and this became a big eye-opener in this field of ultrasound-guided or ultrasound-assisted central neuraxial blockade. In between 2001 to 2004, he not only studied about the spine imaging, but he also predicted various axes for the epidural and the intrathecal space. And with the limited resolution of the ultrasound machine during that time, he was able to identify the various landmarks, bony elements, and the ligaments, and also the spinal canal. So when Dr. Thomas Grew studied the space, depth, and angulation with the efficacy of the ultrasound imaging, he predicted that there is reduced rate of puncture attempts and high rate of success in the form of complete analgesia, and there is less discomfort during the needle initiation among the obstetric patients. So these results are very promising related to usage of ultrasound in central neuraxial blockade. Again, very difficult situation where we'll be having tough times in central neuraxial blockade is obesity, and this study by Dr. Balki had, which is a pre-procedural depth estimation, has predicted that the 75% first pass success rate is there. With 67%, there is no need for any needle redirections, and this is with the patients with obesity, and this is a big eye opener for the usage of central ultrasound in central neuraxial blockade. Now, we have a lot of spine interventions related to, not only related to the lumbar region, we have cervical, we have thoracic, but I restrict my discussion today only with lumbar spine ultrasonography. So to understand the lumbar spine ultrasonography, we should know about the spine anatomy, ultrasound basic physics, and the sonoanatomy pattern and recognition. So starting with the lumbar spine anatomy. So as we all know, it has a vertebral arch being formed by the spinous process, lamina, the articular process, transverse process, and the pedicle. Now, what is very important related to central neuraxial blockade with ultrasound is the spinous process is prominent and it is in the midline. The lamina and the facet joints are antral to the spinous process. The transverse process is more lateral and anterior to the lamina, and the vertebral body is in the midline and the most anterior. So if you want to visualize all these bony elements, the spine, the spinous process will be in the midline, while the facets and the lamina occupy the lateral part, and the transverse process is too deep and is more anterior. That is very important. Now, the vertebral canal is there in the middle, and it is bounded posteriorly by the spinous process and the lamina, and laterally by the pedicles, and anteriorly by the vertebral body. So this vertebral canal contains the thecal sac and its contents. So when we introduce the needle for either epidural or spinal anesthesia, apart from skin and subcutaneous tissues, we have to cross various ligaments like supraspinous ligament, interspinous ligament, and ligamentum flavum. Once the needle reaches the ligamentum flavum, then we have the epidural space, then pierce the dura to get into the subarachnoid space. So this is very basic of central neuraxial blockade. Now, how does ultrasound helps us? When we have a preview scan or pre-procedural ultrasound, it helps to identify as the midline, appropriate interspace. If there is any abnormality, that will be detected, and depth to the epidural space can be measured, and we can plan the needle trajectory and the direction, which all increases the first pass success rate. To do the central ultrasound guided central neuraxial blockade, we need a curvilinear probe. It allows a deeper penetration because the lumbar spine is quite deep, so it allows deeper penetration, and also there will be wider viewing of deeper structures through the bony windows. But the resolution may be poor because of the depth. But nowadays, because of the improved ultrasound technology, this is not a big issue. Now we do get some good images with curvilinear probes too. And as we all know, ultrasound cannot travel through bony elements. So the bone produces hyperechoic reflection with post-acoustic shadowing or dropout. So this produces a classical signature appearance for different bony elements like spinous process, lamina, articular process, and the transverse process in the lumbar spine. So that has to be identified. And once the door is completely closed, and if you are able to visualize a window through which we can identify the vertebral canal, that is the window for the sound wave. When a sound wave can pass through that window, through the same window, the needle also can go and approach the intrathecal space. That is the basic of ultrasound in central neuraxial blockade. So with ultrasound, what we can visualize is the bony structures like the spinous process, lamina, facet joints, transverse process, and the posterior aspect of the vertebral body. So that all can be seen. And the muscles like paraspinal muscles, which are erector spinae, quadratus lumborum, and the psoas muscle, all those things can be seen. Now, in the ligaments like ligamentum flavum and the posterior longitudinal ligament and dura mater, all can be seen. But problem is the ligamentum, we will not be able to distinguish ligamentum flavum from the dura mater, and also we will not be able to distinguish the posterior longitudinal ligament from the posterior border of the vertebral body. No, so we call that as complex. So posterior complex, that involves the ligamentum flavum, epidural space, and the posterior dura. The anterior, this is the posterior complex. So anterior complex, which involves the anterior dura, anterior epidural space, posterior longitudinal ligament, and the posterior surface of the vertebral body. So as we all know, the ultrasound has a property of producing post-acoustic enhancement when it crosses some fluid. So always this anterior complex is brighter than the posterior complex. So to arrive at this anterior complex or posterior complex or various windows, we should have certain steps or sequential scanning. So, to understand that, we should understand certain planes like transverse plane, which is parallel to the floor, and the sagittal plane, which is perpendicular to the floor. So when we place the ultrasound parallel to the floor, it is transverse scan. When we place the ultrasound perpendicular to the floor, it is the sagittal scan. When you place it in the midline, it is called median plane, and when it is away from the midline, it is called paramedian sagittal plane. So coronal plane doesn't play much role here. And we have various sonographic views to understand this lumbar vertebra. Like as I told, this transverse view at the lower spinous process, transverse view at interspinous, that is the window between the two spinous process, and the transverse paramedian oblique, which is not being used very routinely, and the paramedian sagittal view, paramedian transverse process view, the sagittal articular process view, and the sagittal interlaminar oblique view. So, so this is the paramedian sagittal plane view, and this is the paramedian sagittal oblique view. So there is a small tilt oblique view, and this is the transverse scan. So so when we do, this is the first step of identification of the lumbar spine ultrasonography. This is the first step. So when you place the needle at this position, this is called paramedian sagittal transverse process view. So we can view the transverse process. Once you move the probe little bit medially, so this will be happening somewhere around 3 to 4 centimeter away from the midline. So once you start with transverse process, move the probe little bit medially. This is paramedian sagittal articular process view. And the next step is moving little bit medial. You will have the view of the lamina. Now, when you throw the ultrasound beam straight away, where you land up is in the lateral slit of the vertebral canal. To improve the vision, we may have to tilt the probe little bit towards more medial. So that is called oblique view. Now, this is the transverse scan. So the transverse scan, we have two windows. So one is transverse spinous process view and transverse interspinous process view. So, okay, to start with, this is paramedian sagittal transverse view. This is the first step of sequential scanning. So once you see the transverse process, very important step is the probe marker should be always cephaloid, so that the scanning will be always standardized. That movement will be standardized. So this is the transverse process, and we have the psoas muscle, and in the middle of the psoas muscle you will get the lumbar plexus here. This is erector spinae muscle. Now, so the transverse process appears somewhere around 3 to 4 centimeter away from the midline, and this produces a classical sign that is called trident sign, which is because it resembles the threshold, so it is called the trident sign. So once you move little medial from the transverse process, so this is the transverse process view. So the next step is moving little bit medial, so you can arrive at the articular process view. See, the articular process doesn't have any window, so it's a continuous wavy line. So it produces a continuous wavy pattern. So here you can understand this is the inferior articular process of the above vertebra, and this is the superior articular process of the below vertebra. So there is no gap in between them, and the nerve root lies exactly here. So this is not this doesn't play much role in central neuraxial blockade, but this plays a major role for pain physicians. Now this doesn't have any gap, so this produces a wavy pattern, which is being referred as the articular process view, which resembles camel hump. So this is camel hump sign. The next step is moving the probe little more medial to arrive at the lamina. So here you can start seeing the intrathecal space. But problem is, as I told, it is over the lateral part of the vertebral canal. So to visualize the more medial part, you may have to tilt the probe from the paramedian sagittal scan to paramedian sagittal oblique scan. So the degree to which the probe has to be turned medially doesn't matter, is not a standardized one. There is no particular numerical value for that, but it all depends upon the observer and the performer and also the patient to get a better visualization of the a better and wider visualization of the vertebral canal. Now, this is the lamina. You can see the anterior. This is the posterior complex, and you can see the bright anterior complex, and this is the thecal space here. The lamina has a specific pattern which resembles the horse head, so it is called horse head sign. So this is the to compile all. This is the laminar window which produces the horse head sign. This is the articular process window, camel hump sign, and this is the transverse process, that is the trident sign. Now, so this is the scanning. So this is the sacral region. So you can see the transverse process. Then this is the articular process. You can see the Waveri pattern here. And once you move the probe bit medial, you can see the change in the architecture. This is the horse head sign, that is the lamina. So you can see the complexes. This is the anterior complex and this is the posterior complex. Now, for the transverse process, spinous view, always the probe mark will be lateral. So if you place it exactly over the spinous process, you will not be able to see anything beyond that because of the post-acoustic shadowing, and you'll see only the spinous process and the lamina. So, but the vertebral body is there, but you will not be able to see the vertebral body or intrathecal sac. So this resembles a temple bell. So people used to call that as bell sign, and some they refer to that as a tower sign too. Now, once you move the probe, either cephaloid or caudal, with a small amount of tilt to the cephaloid tilt, you can get the interlaminar window through which you can visualize the intrathecal space. So you have the posterior, you have the anterior complex, you have the posterior complex, you have the facets, transverse process, you have the vertebral body here, and here, this is not actually the spinous process. The interspinous ligament too produces some amount of shadowing, but it is not that dark like your spinous process. Now, this resembles a bat swing, so they call it as bat swing sign. So, starting with the midline, the spinous process view, transverse spinous process view. Now, moving the probe little cephaloid, you can see the window is getting opened up. You can see the intrathecal space here. This is a posterior complex. This is anterior complex. Facets are seen. Transverse process is seen, and this is the interspinous ligament. Now, do you have another window, that is transforaminal window or transverse oblique view, not being used very commonly by the anesthetist, but it's very important for the pain physician when they do a selective nerve root block. And anesthetists use this when they use it for lumbar plexus. There is a that's a different topic, lumbar plexus block. Okay, now when ultrasound is getting used for central neuraxial blockade, it will be used for pre-procedural scanning, or it will be a ultrasound assisted or ultrasound guided central neuraxial blockade. So the first step is counting the spinal levels, because we have to mark the exact spinal level where we are going to approach the intrathecal space. So to do that, the ultrasound is placed over the sacrum, which is a continuous hyperechoic line. So once you do a cephaloid scanning, you can see the first gap which is appearing there is L5S1 gap. L5S1. So mark that. From there we can count each and every level. So once the L5S1 gap is identified, we are supposed to mark that L5S1 gap and that interlaminar space. Then like that, we can mark up to the interlaminar space where we want. And this view will help us to identify the wider interlaminar space where we have to place our needle. So you can see the sacrum is hyperechoic line. You can see the first dropout. This is L5S1. So so this is supposed to be L5, L4, and once you move L3, L2, so once you move cephaloid, you can L1, and once you go more more careful at, you will start seeing the thoracic. So this, you are entering into thoracic spine. Once you enter into thoracic spine, you can see the pleural movement and the retroperitoneal space with the kidney shadow there. The next step is how to identify the needle entry point marking. So you, with the transverse scan, the transverse interspinous process view, where we see a wider interthecal space, you can mark it, and you can mark it like this, or the next or another methodology is mark all the lines, mark all the places where the center of the probe, both in the longitudinal and the transverse plane, and the junction of all the 4 lines is the entry point for your needle. So this is the step. So place the probe, identify the midline, mark the midline on the both sides, both on the transverse and the longitudinal plane, where you can see the wider intrathecal space, and this the junction is the needle entry point. So to compile, the ultrasound assisted or ultrasound guided neuraxial block can be done either sitting or lateral position, doesn't matter. The sterility is a very important step, where sterile probes or probe covers are mandatory, and we should avoid gel because it can contaminate the central neuraxium. So saline is commonly used as a coupling medium here. Mark the midline, identify the wide interlaminar space guided by the ultrasound, and mark the needle entry point and the trajectory as guided by the ultrasound. And the depth, when we are going, we can go for depth measurement, and that will be the that will guide us to select the needle also. And very important step in depth measurement is the amount of indentation which we produce with the ultrasound probe. So we have to always add 1 centimeter for the skin to posterior complex depth when we are using this ultrasound as a guide. Now, there are various difficult scenarios do exist, like a patient with obesity, and when you have a patient with multiple co-ops with the implant in situ and vertebroplasty being done, and when the patient comes for this type of implant removal, it's a real big challenge. And when you have distorted anatomy like in scoliosis, these things are very difficult to encounter. And these are all some patients which I have encountered. So this is a 35-year-old female patient who came with the ALL. Actually, she needed intrathecal chemotherapy for her lifespan. And this actually this is a very good this ALL will have a good result when you have when you place the needle and when you are able to give exact intrathecal delivery of the methotrexate. And because of her obesity, the oncologist couldn't do that, and it was referred to Department of Anaesthesiology, where multiple anesthetists tried, and they have all failed attempts. And the call was given to me for, actually the call was for any image guidance. I took ultrasound as the as my priority. And when I put the ultrasound probe, I have found out that the depth at which the epidural space lies is nearly 9 to 10 centimeter with the ultrasound probe. So that means the needle has to be more than 10 centimeter length. So that is why nobody was able to reach the intrathecal space. Now I selected 120 mm needle, which we routinely use it for celiac plexus block in the pain medicine. So I use the after marking the midline, after marking the exact interlaminar space, I went in for the midline mid-space technique. So that is not even a single redirection needed after perfect marking. Yes, we got the CSF in the first attempt itself. Now, the second case is ankylosing spondylitis, where there is no window for the ultrasound to pass on. So the patient cannot even flex the limbs. So here, the ultrasound, when I placed the ultrasound probe, there was absolutely no window at all at the L4, L5 spaces, but I can see a small window which is getting opened up at the L5S1 junction on the non-dependent side. So this is the space which I selected, and I confirmed the same space with the transverse scan. So with the transverse scan, when I confirm the when I did the placement, I can see nothing was visualized at the L4, L5 space. When the probe was moved down, I can see a small space there at L5 S1 junction. So this is the space which I selected. And after proper painting and draping with all aseptic precautions with the probe cover on. So I placed the probe and I marked it. All the sides of the midpoint has been marked, and see the is exactly this is the point where we have to enter, and the ultrasound showed at what angulation the needle has to pass on. And this patient actually there was a need for one-time redirection because of the angulation, and because of the positioning, difficult positioning, there was a need for one-time redirecting. So once you identify all those things, the steps are same, like a landmark guidance, the tactile sensation, what we feel, that are all mandatory thing, even when you do an ultrasound guided central neuraxial or ultrasound assisted central neuraxial blockade. So the big question is, can we do it under real time? Because whatever we had seen is ultrasound assisted central neuraxial. It's not pure ultrasound guided. Yes, can be done. So once you place your needle in the paramedian sagittal view, getting the interlaminar window, and with the interlaminar window, you have to tilt the probe, that is oblique view. So once you are able to identify the posterior dura and the anterior dura, you can place the needle from caudal to cephaloid direction to reach the lamina or the interlaminar space. Now, there is another methodology which has been explained, like the tilting the probe little bit towards more medial, so that the one end lies over the spinous process and the other one lies over the lamina, and you can put your needle again from cephaloid to caudal to cephaloid direction. So this is the patient actually was posted for intrathecal methotrexate with dry needling always. So I did a real-time ultrasound. So this is spinous process, and this is your lamina, and you can see the intrathecal space here, and this is the posterior complex, and this is the anterior complex. You can see the needle approaching the posterior complex. Yes, you can continuously, you can see the needle movement and the needle piercing the both ligamentum flavum and the dura. Yes, so the needle has entered into the intrathecal space and drug delivered there. And sometimes epidural, sometimes central neuraxial blockade helps us in different way. This was done by a anesthesia resident. Under my observation only, the loss of resistance was so good. So I just wanted to see where the epidural needle was placed. So to look at the epidural needle, I just right. The epidural catheter was not in the place actually. So the epidural catheter got misplaced. So to identify that, you can see that you can see the movement of the drug or movement of the air over here. So the intrathecal space lies here. So this is absolutely in the wrong plane, that is into the muscle plane. So okay, so you can see the movement here. So I took up the challenge. I did it under real-time ultrasound. So see, you can see the needle. Okay, this is in the approaching the laminar window. So this is the articular process window. I redirecting the needle towards the interlaminar window. Yes, now the needle is towards the ligamentum flavum. Once it reaches the ligamentum flavum, after that it is the same procedure like your routine epidural, where you have to identify the loss of resistance technique and other techniques. So after the placement, I confirmed this. See, this is bubbling of the epidural space, bubbling in the epidural space, and you can see so once we tried with the air also, you can see that air movement there in the epidural space. So and you can see the same thing in the transverse window. You can see the bubbling here. Okay, so applications of central neuraxial, to summarize, applications of central neuraxial block, application ultrasound for central neuraxial block, we can use it as a pre-procedural spine ultrasound to identify the midline, accurately locate the lumbar intervertebral space, predict the depth of the epidural space or the dura, and if there is any spine abnormality that can be detected, and optimal site and trajectory of the needle incision can be identified, and we can predict the technical ease or difficulty and improve the first pass success and reduce the technical complications. And nowadays we use it for real-time ultrasound guide or assisted central neuraxial blockade. And we have to go for pattern recognition like trident sign, camel hump sign, horse head sign, and the dura, how anterior complex and posterior complex is visualized, and the inter spinous process view, the identification of the intrathecal space there. To get familiarized, so this is the learning strategy. To get familiarized with the gross anatomy, we should have adequate knowledge of the gross anatomy and spine, and we should have repetitive scanning on the human volunteers. And if you have spine phantom model, yes, we can use it for both scanning and needle insertion. And expert-led workshops will help us. And self-directed learning using reference articles. That's what I have done. And there are a lot of online interactive scanning models like which is there from usra.ca virtual spine. So that will help us to learn a lot. So with this, I'll conclude my session. Thank you, one and all, for the patient watching. And at this outset, I would like to thank Professor Dr. Edward Johnson for giving me this nice opportunity. Thank you. Thank you, one and all.